So now we're going to move to the venous transeptal access to the aorta and its branches. How is it done and when can it be done and helpful? By Tilo, Kolbel.
Good morning. Good morning. Thank you very much for the introduction, and thank you, Dr. Veith, for inviting me and giving me the opportunity to present on transeptal access to the aorta and its branches. Transeptal puncture has been introduced in 1958 by Ross and Cope for diagnostic measurement of left atrial pressure, and it became a rare procedure after the Swan-Ganz catheter came in 1972, which allows for measurement of more hemodynamic parameters. During the last 10 years, it has gained more popularity again after introduction of interventional procedures for mitral valve disease and ablational therapy. These are the 3 case reports I could find on the net that describe use of the transeptal access for interventional procedures beyond the left ventricle. And as you can see, there's one procedure for carotid artery stenting, for using a through wire and stabilizing an ascending aortic endograft, and the landmark report on the first percutaneous human aortic valve replacement that was done transeptically. Anatomical landmarks that are important are the aortic valve, of course, and the coronary sinus that have a stable distance to the foramen ovale, which is the intended puncture site. This is what the sheath and the transeptal needle look like. And on these movies, you can see this standardized technique. We withdraw the sheath from the superior vena cava, move it upwards. That is the puncture now. And you can see on the left side how arterial blood is aspirated. Position is confirmed by contrast injection, as you can see here. After that, the transeptal needle is removed, and a wire can be introduced, and it's usually positioned in the left upper pulmonary vein, which allows for positioning of any other curved introducer. Complications, most dangerous is of course cardiac tamponade that requires immediate action. Contraindications, left atrial thrombus, endocarditis. And I'd like to share 2 cases with you where we used this access. First is a fairly young male patient with a ruptured thoracic abdominal aneurysm with a right-sided arch and multiple kinks, of which you see one here in the descending aorta. We did a cervical debranching on this patient, and you see that he also has a very kinked Gothic aortic arch. It was impossible in this patient to advance a standard endograft even with multiple stiff guide wires. And in this situation here, we already had made this transeptal puncture. We have a steerable introducer in place, and we have passed the mitral valve. And you can see how the glide wire can easily be advanced into the ascending aorta, and then can be snared from the contralateral femoral side, as you see here. And this is what the through wire situation looks like when you have a wire through the left femoral vein coming out the right femoral artery. This is after the endograft has already passed the first curve, and you can see how controlled and slowly and smoothly we can now pull and push the stent graft up over the very difficult arch. And in this situation, we got a very nice and stable positioning close to the left innominate artery, and this is the final result. Second patient is a woman with a quite large and very tortuous thoracic anatomy with a thoracic aneurysm with multiple kinks. And here you see the stent graft trying to move it up with 2 ultra-stiff guide wires in place, and there was no way this stent graft would take that most proximal curve in the aortic arch, and it was not possible to do a transbrachiofemoral wire here. And you see in this situation we already had placed the transeptal through wire, and this allowed us to also slowly but steadily move this thoracic endograft up. And this is the last bit of this introduction of the stent graft. You see that it needs a fair amount of pulling to get it around the curve, and here you see the result. So let me conclude. In our experience, transseptal through-wire technique can facilitate endografting in tortuous anatomies, especially when a transbrachiofemoral wire is not possible, and it can stabilize deployment of the endograft. And there's a number of other very interesting indications, like carotid artery stenting or catheterization of side branches of thoracic endograft, as well as ascending aortic endografting. Thank you very much for your attention.